and qualified in both diagnostic radiography and ultrasound, having obtained her education and qualifications in the UK. Mrs. Olsson has been practicing for quite some time as far as ultrasound scanning is concerned. She actually qualified in 1977 and has been practicing since then. She then came to South Africa from England in 1981, working in the private sector before joining the academics in 1985. So since then, she's been doing quite a lot in the field of ultrasound. She is also the co-founder and the director of Sonography Training Solutions, STS, in South Africa, which is a company that is committed in skill development of medical professionals in the field of diagnostic ultrasound, with emphasis on clinical and practical training as far as ultrasound scanning is concerned. Mrs. Olsson has also been involved in so many presentations, including presenting papers during ISRRT workshops, congresses, including the SASOG congresses as well. So tonight, help me welcome Mrs. Susan Olsson. Over to you, Mrs. Olsson.
Thank you so much, and thank you for the invitation to present what is actually a topic very close to my heart, which is ultrasound safety. This article you can download for free, which is a nice word, from the British Institute of Radiology or from the World Health Organization. Gail Tahar has chaired and been on many, many safety committees, and this is one of the most sensible, down-to-earth and quite in-depth papers on the safe use of ultrasound. Which brings us to the question, why do we need to be cautious in the use of diagnostic ultrasound? We've been using it for years. Surely by now we should know if it's safe or not. But most obviously, the reason that we look at is for biological safety. And if you talk about ultrasound safety, that's probably the first one that comes to mind. But there are other factors which we need to consider in the use of ultrasound in a slightly broader medical context. And so we're going to look at electrical and mechanical safety very briefly, operator safety, which might not be the first thing that comes to mind, and the standard biological safety. These are common sense. We have machines that sit in the ultrasound room, they're plugged into the wall, we use them day in, day out. And can you be honest with yourselves, how many times have you actually checked the plug and the cables and the wiring? Probably not very often. And this is just an example of what can happen if they overheat. And then obviously you're putting your machine at risk, as well as a fire hazard. These are just standard ones. They come in the manuals that come when you buy a new machine. So I've just pulled them out just in case you don't read the manuals to the end, which a lot of people don't. There is an electrical presence, so inflammable gases may produce a risk. How you clean your transducer, and hopefully you do clean your transducer, has to be cleaned with very special chemicals. And I put there in brackets, no alcohol. That's not for the sonographer. That it came about because of COVID. And we were told by the people whose machines we use in our training courses that you cannot use hand sanitizer to clean the transducer. It sounded just so simple and so obvious. But the 75–70% alcohol in hand sanitizers actually seriously damages the transducer over time. So alternate cleaning needs to be used. Removing the transducer if they're defibrillating is a basic common sense. The next one, not so much. When you move the machine, or if somebody moves it for you, or it has to be taken to a ward to do a portable, just be careful of not running over the electrical cables. or the cable linked to the transducer. If any of the wires inside those cables break, then you're going to render your transducer not necessarily completely inoperable, but most certainly not working to its full potential. Static electricity obviously will affect it, and it affects the image. So if you have it next to electrical equipment, make sure that it's shielded from those electrical signals. And logically, don't remove the covers while the unit's on. You're going to give yourself a very, very nasty shock. This next one is one that maybe people don't think about, because most time people think about the patient, and particularly the pregnant patient. Recently, probably in the last 5-6 years, people are starting to look at the safety of the person actually doing the scanning. I was at a congress 5 years ago, and one of the parallel sessions was ultrasound safety. So I thought, oh, great, I'll go to this because this is my pet subject. The entire session was not on patient safety. It was on safety of the person doing the scan. And why was that? Well, as you can see, a recent survey in the UK, 80% of sonographers admitted that they worked with some level of pain. And it was as a result of doing the scanning. An earlier one in the United States, a few years back, said that 20% of sonographers did not have a full working life because of industrial injury. And that's actually quite scary. And I'm sure some of you will be aware that after you've done a really hard day's scanning, your right arm, if you're right-handed, left arm if you're not, are really quite sore. And it starts with the neck, shoulder, and elbow of the scanning arm. People who stand to scan, you're going to put your back out, so your back is going to go. And then ultimately, the pain and the problems move over to the non-scanning arm. Now, there's an awful lot we can do to actually mitigate the pain of scanning. Please always scan seated on a height adjustable chair with a low back support. Do not have armchairs, chair arms on it. It's not an office chair. Those just get in the way. Make sure that you look at 90 degrees to the screen, particularly with obstetrics. You have a tendency to turn the screen slightly towards mummy so she can see too, and that is going to throw your positioning out. So 90 degrees to the monitor and approximately 20-degree downward tilt. And this is why on most of the really new machines, you can adjust the monitor to that requirement. And then have the patient in the examination couch as close to you as possible so that you're not reaching the whole time, particularly when you're scanning the side furthest away from you. And if possible, rest your arm on the patient's body. They don't mind. It's not intrusive, and it just helps to take the tension out of the muscles of those arms. And if you look below at the grip, that with the resting of the arm makes scanning much more easy. Now, on the left, we have got what I call the grip of death. And this is the one, if you look, you can see the white of the knuckles. And if you hold the transducer as tight and as hard as that, two things are going to happen. You're not going to be able to make the really small finite movements required to just finally tweak that really, really, really good image. But also that tension is going to move right the way up your arm into your neck. On the right, you can see that the hold on the transducer is much gentler. I personally hold the transducer slightly higher up because I do have a thing about getting my fingers in the gel. So I don't scan with my hand touching the patient, but a lot of sonographers say they do because it helps stabilize the transducer. That is your choice. But that relaxed grip on the transducer allows you to more freely move it and position it exactly where you want. The room itself also is important. You should be able to darken it with a possibility of a lamp for rewriting your report if you send out reports. Temperature is important, not just for you. If it's too cold, you're not going to be happy. If it's too hot, you're not going to be happy. But also the machine itself gives out quite a lot of heat. And so if the room isn't well aerated, then that machine is going to overheat. And I've been working in practices with my students in the past, where by the end of the day, the heat buildup has been such that the machine is actually no longer working at a point where you can actually say that it's its best scanning possible. If you do a lot of obstetric scanning, it's nice to have a slave monitor so that the patient and their families can watch without you having to turn your screen. Obviously a wash basin and a bathroom, especially if you're obstetric and gynae patients, because by the time you've finished your scan, the bladders are not going to take a long walk to the toilet. Okay, we now move on to the patient, the important one. These are just some definitions that we need to think about when we're looking at the physics of ultrasound safety later. And the spatial pulse length, that is the length of each pulse, and it's the number of cycles in the pulse, which is usually in the region of 3 to 4 for basic diagnostic scanning. As you can see from the little picture, the pulse repetition period is the distance from the beginning of one pulse to the beginning of the next. That listening time will alter according to the depth that you have set for your image, because you cannot send out the second pulse until all the echoes have come back from the first pulse. The machine would not be able to calculate which echo came from which pulse. Now, the duty factor is the time that the transducer is transmitting. And in our pulse echo system, it's only transmitting for approximately 1/1000th of the time that you are scanning. And the other 999ths is when it's listening. Now, the one that's in red is because this is important in terms of safety. And this is the time that the ultrasound beam is interrogating the same area of tissue and not moving. So the biological safety is important and very controversial. And the big problem is there are so many opinions on whether or not ultrasound is safe. And if you just Google ultrasound safety, it comes up with, here is your first 10,596,224 articles, and half of them say it's safe and half of them say it's not. But what we do know is that there are problems. And so although people for decades have said ultrasound is safe and are still saying it, but if that's true, why do we still have so many safety committees all over the world looking at the use of ultrasound? And this is where we're going to start to look a little bit tonight. And bioeffects from ultrasound were discovered right in the very, very, very early days of ultrasound research. And I've been doing some research recently for a paper that I'm presenting on the history of ultrasound. And in the beginning of the 1900s, researchers were looking at sonar, which is where we came from originally, underwater ultrasound for the detection of objects such as submarines in World War I. But what they noticed was the shoals of fish traveling through the water into the ultrasound beam died, and they were killed by the high intensity ultrasound. So even as early as that, people were realizing that there were potential issues with the use of ultrasound. And so what most of the research is looking at at the moment is the potential for harm. And that is the major point of discussion. And probably the problem with it is that ultrasound technology has developed so rapidly that it becomes almost difficult for the research to keep up. So the safety committees started issuing statements, and one of the early ones was the World Federation for Ultrasound in Medicine and Biology, and this is in 1999, that the greatest hazard in diagnostic ultrasound was actually people misdiagnosing. And in those early days, and you looked at the quality of the machines that were available in those early days, they basically didn't know what they were looking at. And without proper training, I'm afraid that still might be one of the issues of ultrasound safety. More recently, 2013, ultrasound examinations should only be performed by competent personnel who are trained and updated on safety matters. And then they added a very important one, which is also important, that ultrasound devices are appropriately maintained. Now, one thing that I've discovered doing the training over the last few years is that people will buy an ultrasound machine and they will use it for 10, 15 years and never have a technician come near it in that time. And that's basically akin to buying a car and never ever having it serviced. And that's not something we do. We know that is wrong, but it's also wrong to leave your ultrasound unit. And with the digital ones that we use nowadays, software upgrades are so easy that the technician can put them in and keep your machine up to date and working well with very little effort. Then in 2011, we had a statement that said diagnostic ultrasound has been used in clinical medicine for many years with no proven deleterious effects. Well, if this is true, why do we still have safety committees? Now, I'm a very cynical person, and I looked at that statement and I said, that's okay, no proven deleterious effects. What do we do about the unproven deleterious effects? Because those are the ones that are going to catch you out. To give the European Commission its due, the next sentence to that statement says, if used imprudently, diagnostic ultrasound is capable of producing harmful effects. So that is why we still have safety committees. And this is a statement that I really like. It must be remembered that the absence of evidence of harm is not the same as the absence of harm. And that is just something that as ultrasound operators, we should keep at the back of our mind. As I said, the bioeffects have been studied since the early days of the research, and they're well documented and proven to exist. We can use ultrasound to kill tissue. That's part of therapeutic ultrasound, to ablate fibroids. But what is their potential for harm in diagnostic applications? And that is something that we need to look at. And over the years, a lot of concerns have been raised about what ultrasound might do. In the very early days when I started, all the scaremongers, the babies were all going to be born deaf because we sent sound through the temporal lobes where the hearing centers were. And that is not true. Multiple ultrasound scans during the pregnancy causes the babies to be born with low birth weight. That has come up on research, but the follow-up research was that by the end of the first year, they were equal to their babies that had not been scanned. An increase in left-handedness amongst boys. This also has been proven. And then you can say, well, what's the problem with being left-handed? Lots of people are left-handed. But what you've got to think is, if the baby was meant to be right-handed and is now left-handed as a result of exposure to ultrasound, what exactly happened? Delayed neuronal migration during the fetal development. This has been proven in mice, but the machine that did it was used to excess and in no way in the format that it would be used on a human pregnancy. But yes, it can delay neuronal migration. There was a research that said it increased sister chromatid exchange during cell division. Again, that has been discounted by other research, so that is debatable. Ultrasound does not cause cancer. And the latest one that was a statement issued by ISUOG literally only a couple of years ago is there is no link between ultrasound and autism. What can happen is that ultrasound can cause capillary bleeding in the mucosa of the lung and intestines in neonates, and those that have been tested have been rats, mice, rabbits, pigs, primates, monkeys, not been tested on humans, but I do think that if it's on all of those other animals, then there is no reason to believe that it may not happen to a human neonate if care is not taken. Why must we doubt some of the research? Well, this is why. Some of the safety statements were published before 1993. And in 1993, the Federal Drug Administration in America raised the upper safety limits of ultrasound that we can use when scanning 8-fold, from 94 milliwatts per square centimeter to 720 milliwatts. And this was because of the manufacturers bringing in higher end modalities. And this is when Doppler was beginning to come in, for example, and you needed those intensities for them to work. The other thing is that experiments are performed on mammals and not humans, obviously because of ethics, and that the results published are often in vitro results, which means they're research and not in vivo. And as with left-handedness amongst boys, a slight increase in a common trait might be difficult to identify and may actually take several years to identify, by which time it's a bit too late. We are doing more and more with ultrasound from the very early days when I started in terms of the applications that we can use. And as I said, some of these require these higher acoustic outputs, these high powers. Some of the early studies did not mention in that research what the control settings were on the machine so that you could see if any of those had an impact on the results. And now with the number of patients undergoing ultrasound examinations, it's becoming quite difficult to get control groups. And if you go on to some of the websites, you'll see articles, is the art of clinical examination dead? Because people don't clinically examine anymore. They do an ultrasound. Ultrasound, the new stethoscope. So there you go. So bioeffects that we do know depend on the intensity of the beam predominantly, but also the beam shape, how long the patient is exposed to ultrasound, the scanning mode, and we'll talk about that a little bit, as well as the frequency used. And the two major effects which were considered in the safety studies are thermal effects. When ultrasound energy passes through the patient, a lot of mechanical effects take place, ultrasound interactions with the tissues of the body, and that in total weakens the beam. This is total attenuation of the ultrasound beam. When you scan with the lower frequencies, most of the energy from the tissues is returned back to the transmitted beam. But at high frequencies, that doesn't happen, and more of the energy is converted into heat. And so the tissues start to heat up. Now, this is what the effect that is wanted when you have therapeutic ultrasound with physiotherapists. They use ultrasound to heat up the tissue as part of the healing process. But we don't want to change the tissue. our patients, we want to go and leave our rooms exactly the same as they came in. So this heat development can be problematic because hypothermia is a known teratogen. And as with so many other drugs, radiation, etc., that's a very important consideration in the first trimester of the pregnancy when the fetus and embryo are developing their different tissues. But also from a physiological point of view, heat can affect the rate of chemical reactions, can affect the rate that they take place, and it can alter the equilibrium between chemical reactions. And so you can change the physiology of tissues with heat if it's too high. Now this graph it's an old graph, but it was revamped post 93. And this gives you the idea of what can happen with intensities over time. And you can see from here that we can have high intensities, but for very short spaces of time. We can have the lower intensities, and bearing in mind this is in watts per square centimeter, and our upper safety limits are in milliwatts. So the lower intensities we can actually use for longer periods of time. And you can see that there is a definite safe zone and a definite hazard zone. Where the concern is at the moment is that with the increased outputs, that we are slipping into that gray area, which I call the don't know zone. And if it does go into that gray area, are there ramifications to the patient that we still are not certain of? Now we have non-thermal effects. Bearing in mind from the physics of ultrasound, which I'm sure you've all done, is that when the energy travels through the tissues, molecules in the tissue are made to vibrate around their resting point. And if molecules are being shaken about by the passage of this energy, there may be problems with that. And the non-thermal effects basically are cavitation, which is the expansion and contraction of existing bubbles, or the development and collapse of new bubbles during the oscillatory cycle, the wave formation of the ultrasound beam. These bubbles get bigger or implode in the rarefaction half cycle, which is when the particles in the body are being stretched apart. Streaming is the movement of fluids due to the radiation force of the ultrasound pressure. And if we look at this, stable cavitation is referring to existing bubbles. And you can see as they get bigger and they vibrate, we get microstreaming and shear forces. The transient is the formation of new bubbles. And again, in the rarefaction half cycle, they implode and they give out very, very localized heat, free radicals, shock waves, and shear forces. The belief is this is not so much of a problem in the diagnostic scanning range unless there is the presence of ultrasound contrast, because ultrasound contrast are microbubble contrast, which increases the echogenicity of the tissues that they pass through in the bloodstream. Having put up the intensity limits by eight times, the Federal Drug Administration then determined that all ultrasound machine must display 2 safety indices on the monitor, and they are giving the operator the information of the likelihood of thermal and non-thermal effects. Now, interestingly, the upper limit for eye scanning wasn't raised because of the sensitivity to eyes from damage from the ultrasound exposure. And the result can be the same as exposure to radiation, which is the formation of cataracts. Now, when you scan a fetus, we're going to be scanning the face for normality in a full fetal scan. And we're going to be scanning around the face to find our BPD. And the belief is that this fetal eye is not quite so compromised as the adult eye because it's lying in a bed of fluid, and the amniotic fluid can radiate heat away from the eye more easily than in an adult, because the eye is not a very good vascular structure for the blood supply to take the heat away. So the thermal index, TI, is a mathematical calculation, and it's the amount of ultrasound power used to this mathematical requirement that will give a temperature rise of 1 degree. And this is where some of the other researchers have an issue, because this is a mathematical solution and not a real life solution. So this is a little bit controversial. So they have 3 sub-indices: this index in soft tissue, in bone, and a special one for the cranium, because as with radiation, the central nervous system, particularly the spine and the brain of the fetus, is most sensitive to damage. Now, bone absorbs ultrasound energy more than any other tissue, and in doing so, it will heat up. So tissues next to bone, i.e. the cranium with the brain inside, may heat up more than other tissues. And the full bladder, well, what's the first thing we do when we're doing an early pregnancy? We ask them to fill the bladder. And as a result, the sound intensity traveling through the urine is not weakened, it's not attenuated. So when it hits the uterus behind the bladder, it is hitting that uterus with a small gestation sac in it at pretty much full strength. So these are sort of things that you have to keep in mind as a back of the brain idea when you're scanning, because you are the one that is controlling this. But the beam shape and the intensity levels also complicate the process. So the mechanical index gives an estimation, not an absolute, an estimation of the risk of the non-thermal effects, which is cavitation, microstreaming, and large molecule disruption. And this is the only society that I've found that actually gives values that we can work with when we are scanning to try and limit any potential, and I keep using that word, potential for harm from our scanning. And so an MI greater than 0.3 value is a risk of capillary bleeding. More than 0.7, there's a cavitation risk. TI of 0.7, you have to limit your exposure when you're scanning. So ideally from that, you can see that TI of less than 0.7 and an MI less than 0.7 are our ideals. And the MI, if you can get it below that, even better. Now, having said that, the manufacturers also have to take a responsibility for this, and they must make sure that their machines will not work above any threshold values. And this picture is just showing you where your MI and TI show on the screen. And you can see the TIS there is 0.4, which is good. This is a carotid scan. The mechanical index, however, is 1.3. The reason for that, we have got color Doppler on. And using color Doppler with high intensities has raised our MI value. Still within safety, but very, very high. But the other thing too here is looking at this on the B mode, they are scanning at 100% power, and also on the color flow, scanning at 100% power. That is not necessary. You do not need to scan at 100%. You can drop it quite easily and still produce excellent, perfectly good images. So if you look at all the safety statements, and this is a conglomeration of several, that medical ultrasound is safe for B mode and M modes. These are low intensity modes. Where the concerns are expressed is for Doppler, all forms of Doppler, power Doppler, spectral analysis, and color flow, and particularly for the obstetric applications, and especially for the first trimester. ISUOG, I don't know if you've heard of ISUOG, it's the International Society for Ultrasound in Obstetrics and Gynecology, and the World Federation, 2009, this is getting quite old now, machines have been changed quite a lot, is that pulse Doppler should not be routinely used in pregnancy and should actually be avoided definitely in the first trimester. Pulse Doppler ultrasound can be used for clinical indications to refine risk for trisomies, by which time you're in the realms of the fetal medicine specialists. And obviously they work in far different realms to mere mortals like me. So when performing Doppler ultrasound, the displayed TI should be less than 1 and the exposure time as short as possible and no longer than 5 to 10 minutes. This is logical, but unfortunately, because people have thought that ultrasound was so safe for so long, in a lot of cases, particularly with obstetrics, it has become treated like a toy. It is not. It is a serious medical modality with a risk to benefit ratio. And so it should never be performed if there is not a valid medical reason for it. So baby pictures for the album for mummy before the baby's born, every safety statement decries that as a practice. Fetal heart rate, mummy does not have to hear the heartbeat. If you do M mode, which is a much lower intensity and therefore much safer, or show mummy the baby's heart beating on the screen, they get just as emotional as hearing it. And obviously, from those definitions that we did earlier, the dwell time, the time that you scan the same area of tissue over and over again, should be as short as possible. Scanning modes have a role to play as well. And this is why when you look at the safety statements, the safe modes are B and 3D scanning. And that is where the sound beam is being moved over different areas of the body constantly. And so you don't have a dwell time of any length. The non-scanning modes are ones with a high dwell time, which is M mode, Doppler, and 4D, where the transducer is being kept stationary in order to achieve the information we need. And so again, the risks are higher with these modalities. So as a result, ultrasound has now followed diagnostic radiography in having the ALARA principle, as low as reasonably achievable. And this is now advocated by every safety committee, every safety statement when you see scanning guidelines for operators. So the problem then is that in the absence of hard and fast rules, regulations, or even laws, the regulatory bodies were very, very clever. They passed the buck onto the sonographers, sonologists, and the person doing the scan. So we are now responsible for our patient's safety, for the safe and judicious use of ultrasound. So this is why you need to know about ultrasound safety and its pros and its cons. So the ALARA principle is the operator trained and conversant? Do they know what they're doing? Do they know what TI and MI mean? And do they know how to monitor it? Is there a valid medical reason for the exam? Non-diagnostic scans should not be performed. Reduce the acoustic power at the start of the scan, and most machines automatically will default to 100%. Now, there's another side to this apart from safety. If you work at high intensities, what you are actually doing is effectively widening the beam. And from physics, we know that the lateral resolution is best when the beam is narrow. So if you scan at 100%, not only is it impacting on safety, but it is impacting on your image resolution as well. So there's two reasons for dropping your output power from 100% down. Choose a suitable frequency at the beginning of the scan. THI can be deactivated on a lot of units, and there are times when you don't need it because THI raises the MI figure. And also complete the examination within the recommended timeframes. In other words, the ALARA principle, a good, thorough examination with the control set properly in the least time that it takes to do a good scan. For obstetrics, TIS values should be in the first trimester, and once the skeleton starts to calcify, switch to TIB, thermal index for bone. Doppler contraindicated in the first trimester, 4D scans, and the fact that most obstetricians scan the baby every single visit for mummy, that is not actually required. Do a proper scan at the correct time for fetal anatomy, and then you do not need to scan every time. And again, Doppler for the fetal heartbeat. If you're using color and power Doppler applications, don't use a narrow box because that increases the intensities. Limit examination to the face, limit to the fetal cranium and spine, and inform consent from the patient. Now, the zoom control, most times it's used is when you've got the still image, the frozen image, and you want to enlarge a particular section of that image for inspection or measurements or whatever. But you can actually have the zoom button on when you are scanning and you scan an enlarged image. And this can be very helpful in some cases, and a lot of the fetal medicine specialists use it when they are looking for their posterior fossa anomalies and cardiac anomalies in the first trimester. I couldn't do that, but these people do. But it does raise the MI values quite significantly. So the conclusion to all this, ladies and gentlemen, and thank you for your patience, is that diagnostic ultrasound can still be considered safe, provided that cognizance is taken of the potential for harm. And so with formal training and the ALARA principle, we are perfectly able to protect our patients. And what we all hope is that in 10, 20, 30 years' time, people turn around and say, fabulous, ultrasound was safe after all. And I hope that's the case. If not, in 20, 30, 40 years' time, I won't be around by then for sure. But we can say, you know what? We did our best with the knowledge we had to adequately protect our patient. And there you are. If you have faith, you can climb mountains and ride big horses. Thank you so much for giving me the time to do this. I really appreciate it.
Thank you. Thank you so much, Mrs. Olsson, for this wonderful presentation on ultrasound safety. You have touched on so many aspects, safety in general, as in economics of in ultrasound of sonographers, how to take care of ourselves during scanning. You have also touched on even like maintenance and of our machines and our cables, cleaning of our probes and our ultrasound machines. We have touched quite a lot of issues. What I've discovered is, you know, during scanning, it's very few of us usually touch the power button to adjust the power. Mostly people just go on and start scanning without even checking the MI and the TIS values on the machines. But you have brought in an important aspect of ultrasound safety. Thank you so much. because of time, I'm going to leave this time to all those that have questions, that have any questions, to ask, all those who have comments, all those who have whatever they want to add or comment on the presentation. This is the floor